Sir, do we begin or do we wait another minute?
Yeah, maybe you can start off slowly.
Great.
But we
Good
have
evening.
not finished.
Good evening and a very warm welcome to everyone present here. It gives me great honor to welcome and introduce Dr. Pradeep Rangappa, Dr. Sunil Karanth, and Dr. Himal Dev. My name is Siddharth Bhardwaj, and I'm the Senior Product Manager with Fish and Paykel Healthcare. Today's topic is of relevance, and we have experts here to deliver to us the importance and the validity of the same. Very firstly, it gives me pleasure to introduce and welcome Dr. Himal Dev Ji, the consultant and head of intensive care at the Apollo Hospitals, Sheshadripuram. Doctor obtained his MD in anesthesiology with a gold medal from the KMC Manipal in 2012, followed by an FNB in intensive care medicine in 2015, followed by a European diploma in critical care in 2016. Dr. Himal is very passionate about intensive care management, ECMO management, airway management, etc. He has to his credit several academic achievements and research publications. Without further ado, I'd like to hand over the baton to Dr. Himal, and over to you, sir.
Thank you, Siddharth, for the introduction. So good evening, everybody, and it's my honor to moderate this session on HFNC therapy and humidification in critical care setting with two of the stalwarts in critical care who doesn't need any introduction, Dr. Pradeep Rangappa and Dr. Sunil Karanth. This talk indeed is a very important one considering the recent pandemic and usage of high flow oxygen therapy. And who else is better than the speakers today to elaborate and also spread more awareness and knowledge on this subject. I welcome Dr. Pradeep Rangappa sir and Sunil Karanth sir for the discussion. The first talk is on the high flow nasal cannula therapy. Dr. Pradeep Rangappa will be speaking on this topic. He is the lead consultant and intensive care physician in Manipal Hospital, Yeshwanthpur. He is accredited with Fellow of Joint Faculty of Intensive Care Medicine from Australia. He holds an EDIC degree and FCICM degree from Australia. He also has done a PG diploma in echocardiography in intensive care from University of Melbourne. He holds MBA in healthcare sciences and also a postgraduate diploma in medical law and ethics. He has been a national vice president of ISCCM, secretary ISCCM Bangalore chapter. In addition to above, he also has been an organizing secretary for Criticare 2015 and Gap Year 2016. He has got many research publications in his name and is very academically active on various communication mediums. I request Dr. Pradeep Rangappa sir to start with the topic. Thank you, sir.
So, okay, you're able to hear me, right?
Yes, yes, sir.
Yeah. Thank you, one and all. So I'll jump into this topic. So the way I'll divide this topic is the first 10 minutes, I'll talk about the technical aspects of this high flow nasal oxygen therapy. I'm sure many of the listeners would have already used this, and there was a lot of expertise that was gained during the COVID time. And the second part, I will talk about all the evidence. So I was quite bewildered to see the amount of evidence that is generated since the first paper that came out in around 2015 about the benefit of this particular equipment. So today I won't be talking about its evidence or role in COVID per se, but I'll talk about general ICU conditions, predominantly respiratory failure. So when we look at HFNC and compared to the nasal cannula, there are certain distinct advantages. As the name sounds, high flow, so it's a high flow oxygen device. And compared to the other conventional, so it is documented to increase the functional residual capacity by about 25% with the use of HFNC as compared to the conventional oxygen therapies and reduces the dead space. So I'm sure most of the listeners would have seen this equipment stationed in their ICU. So it has various components to it. So one of them is the gas source, and one of them you have this pressure relief valve, and you have a humidifier. I think that is the key aspect which humidifies the oxygen. And then you have a nasal interface. It's not like an NIV, it just sits into as a nasal cannula. And that is a distinctive advantage where you do not have issue with compliance or claustrophobia. So just breaking down the things, you have a flow meter, which is very unique to this device because it generates high flow rates, even up to 60 liters per minute. So that's why you have these flow meters which are customized to this high flow device. And that is something one needs to bear in mind. And the flow is equated to the titratable FiO2. And generally those charts are given along with this. So you can refer whenever we are using this as to at what flow, what sort of an FiO2 is delivered. Then you have an air oxygen blender, you have a sterile water for humidification. Then we have a heated breathing circuit and nasal cannula and active humidifier and heater. So the flow settings are fairly simple. So there is an autofill water chamber, then there is an oxygen inlet and integrated blender and analyzer. As I said, the flow that gets generated is anywhere from 20 to 60 liters. So at about 60 liters flow rates, you can deliver up to 100% of the FiO2 that may be needed for severe hypoxemic respiratory failure. And then these equipments have inbuilt temperature sensor. So the whole advantage of high flow nasal cannula is it sits like a nasal cannula. So the ease of administering, the compliance, comfort, and we do not have issues with the pressure effects of these devices, unlike some of the NIV device where you may have claustrophobia, compliance issue, and patients getting to keep it, and the pressure source, and so on and so forth. So that aspect is something that is negated with this HFNO. So there are few additional benefits that one gets when HFNC is being utilized as compared to conventional oxygen. So during inspiration, there is some amount of a PEEP that is generated during the inspiratory process, and it is a flow dependent breaths, and there is some amount of pressure that is generated, and it does promote slow and deep breathing, and it is shown to improve the alveolar ventilation during the inspiratory phase. And during the expiratory phase, it has, because it generates a bit of a PEEP, it has ability to clear the secretions well. So it is effective in clearing upper airway secretions. And it does reduce the rebreathing of gas within the with high CO2 within the oral cavity. So that is another distinct advantage during the expiratory phase. And it is shown to reduce the dead space ventilation as well. So in the expiratory phase. So these are some of the advantages that it has. So a bit of a pressure generated and effective in clearance of mucus secretions, prevention of rebreathing, improving alveolar ventilation, reducing dead space. So these are some of the additional benefits that it confers when compared to conventional oxygen therapy. And as I said, the humidification is another distinct advantage because it has a water heated humidifier. So the air that is breathed is humidified effectively. And most listeners would be well versed in how important is humidification because humidification is very much needed for good mucociliary clearance of secretions, which is often an issue to cause secretration of the whole mucus secretion. So humidification helps in clearing of these secretions and prevents sequestration of these. And it helps in good mucus clearance. So this is also some of the advantages with HFNO, which possibly we won't have in conventional oxygen therapy. And it is an open system. Like in NIV, we need to put a lot of energy and emphasis on a good mask seal, isn't it? So that possibly is not needed because it's an open system and there is no seal that is needed. And it snugly fits into the nose and it is very comfortable. It does not cause any pressure source or excoriation or ulcerations in the nasal mucosa, because of a good humidification and an open system and a good compliance that is comfort. So these are some of the technical aspects of HFNO. It can be called a HFNOT, high flow nasal oxygen therapy or high flow nasal cannula therapy. So it can be changed interchangeably. So comfort and tolerance is the key sort of a distinctive feature of these HFNOs. So there are certain criteria which has been accepted as possibly that we could agree upon that it can be used. So it has a reasonably good body of evidence in hypoxic respiratory failure. So as I said, I was quite bewildered to see the number of articles that I've generated since 2015 in this area. So I'll take you through some of them. And there is a sort of conditional recommendation in patients following extubation where there is a risk of possible reintubation where it has shown some benefit following extubation in certain group of patients where there may be a risk of ensuing respiratory failure and reintubation. And there is conditional recommendation in the post-operative respiratory failure or post-operative atelectasis where the oxygen that would be needed may be much higher, and high HFNO can be looked at as one of the alternate for the other oxygen devices. And for the peri-intubation, like if for pre-oxygenation, this possibly is not applicable to our ICU setting. So as a pre-oxygenation strategy in OT, there are few studies that have come. So we won't touch today about this aspect. This is more of anesthetic perspective. So these are some of the recommendations that are based out of a lot of studies that have come out over last 10 years. Over a decade, there are huge body of evidence that has been accumulated in this HFNO. So when we look at evidence, as I said, I was very pleasantly surprised to see the number of articles that have come. So in fact, the one article which made a lot of news was in 2015, which we have discussed in our multiple forums, which was a Florali trial. So that came from the French group, and that really paved pathway to multiple other studies that came in after that in this area. And if you see in hypoxic respiratory failure itself, there are 14 randomized controlled trials that have been generated in HFNO. So there is mammoth amount of evidence that has been accumulated in this area. And there are 4 meta-analyses just in hypoxic respiratory. That's why possibly it gets a better sort of a substantiation. And in immunocompromised, there is 1 prospective study and there is 1 randomized controlled trial. And there are 2 post-hoc studies in immunocompromised. And post-extubation respiratory failure, there are 2 randomized controlled trials. And post-surgical respiratory failure, even there where one would believe there may not be too many, there are 9 randomized controlled trials and there are 2 meta-analyses. So this is the sort of body of evidence that is currently available. So obviously we won't go through each and every trials, but we look into what are the robust sort of the evidence that at this point of time we can look up to substantiate ourselves in using this HFNO. So we had to start this discussion with the Florali trial because that was the study which came in 2015, which excited all our intensivists. I'm sure Himal and Sunil would agree in this forum that this was the study which was extensively discussed. This came from the French group in NEJM. It was called a Riva network group that came in NEJM. So this particular study was done in non-hypercapnic hypoxemic respiratory failure. So they took only type 1 respiratory failure. And they compared 3 strategies of therapy, HFNO versus what is conventional oxygen therapy and NIV. So they compared these 3 modalities and they took patients who had PaO2 by FiO2 less than 300. So, or at that point of time, it would have been called acute lung injury. They took these patients. So the primary outcome was to look at the day 28 intubation rate. So they basically saw that whether by using HFNO, they could reduce the intubation rates as compared to NIV. And the secondary outcome, they looked at all-cause mortality, ICU mortality, and day 90 mortality, and day 28 ventilatory-free days. So these are some of the outcomes they looked at. When you look at the results, the primary outcome was to see if HFNO was successful in reducing the intubation rate. And this was, so 310 patients, 106 were in HFNO, 94 in conventional oxygen therapy, and NIV 110. As you see, the intubation rate, it failed to show any demonstrable benefit. So it did not achieve statistical significance. There was no difference in intubation rate. And but what it showed is day 28 ventilatory free days, which is a good indicator. That was higher in HFNO, which means it reduced the duration of ventilation or oxygen need in these patients. So that was a positive thing. But interestingly, what came out of this Florali study, which excited all of us, was the mortality. So they looked at 90-day hazard risk of death between the conventional oxygen therapy and HFNO, and they found the death was more in conventional oxygen therapy as compared to HFNO, that attained statistical significance. But this did not excite us because obviously HFNO, you're giving more oxygen, they might have done well as compared to conventional. But what excited all our intensive care group was its comparison with NIV, where 90-day hazard risk of death was found to be more in NIV as compared to HFNO, and that attained statistical. So this raised a lot of eyebrows amongst us as to because until then we were only depending on NIV as a source once they failed on conventional oxygen. But here this study came telling that HFNO fared better than NIV in reducing the deaths. So that really excited. Obviously, when you dwelled into the study, there were a few other nitty-gritties that would have explained this. We will not dwell into that. But the conclusions they drew at the end of this was in non-hypercapnic hypoxemic respiratory failure, comparison between these 3 groups, although it did not show any difference in intubation rate, HFNO usage led to lower 90-day mortality. So this excited all of us. And then possibly this study paved the pathway for multiple studies that came after that. So we'll talk about the 4 key meta-analysis that came. So this is the one of the latest meta-analysis is this, which came from the US group. This is the largest meta-analysis. This came as late as 2021. So meta-analysis of 14 trials. They compared HFNC with the conventional oxygen therapy, and intubation rate was no different. And the escalation of respiratory support, they compared between HFNO and conventional. Again, there was no difference with regards to the need for escalation. So this was sort of a negative study. Basically, it's a meta-analysis taking all the 14 randomized controlled trials done in hypoxemic respiratory failure. We did not show that whether it really reduced the intubation rate, but what it showed is it improved the dyspnea for the patients. The subjective symptoms of dyspnea and comfort level was more, and one trial showed it did help in reducing the hospital-acquired pneumonia. So this was the previous year one, which came in 2020 by the Canadian group. This was a meta-analysis of 9 good quality trials they took. And this was a positive trial where they showed a positive study rather. Intubation rate was significantly reduced with HFNC. As you see, the confidence was also significant. And the escalation of respiratory support was significantly reduced with the use of HFNC. And again, you see confidence intervals being significant. So this is another meta-analysis with a good, robust randomized control trials that was taken. And they found HFNO help in reducing the risk of intubation rate and reducing the need for escalation of respiratory. When you say escalation from HFNO, someone possibly getting worse, needing intubation, or possibly getting NIV, so on and so forth. And but mortality, length of stay, there was no difference between conventional oxygen therapy and HFNC. So this was another meta-analysis. I'm sure the listeners would know China has done a lot of meta-analysis. This came from the Chinese group. So this was meta-analysis of 6 trials. They looked at HFNO and conventional, and even in this study, intubation rate was significantly less with the use of HFNC. But the problem with this study was they used mix of patients. They did not take only hypoxemic respiratory failure. 2 studies took that. 3 studies took post-extubation. So 1 trial took broncho. So it was a mix of all these patients. So we cannot say this study was purely looking at hypoxemic respiratory failure, and that was the flaw. That's why I would call this study as a equivocal. But what they found in this study was when they compared with NIV, as Florali did, HFNC with NIV and HFNC with conventional oxygen therapy and the need for NIV, there was no difference. So even when comparison with NIV, there was no difference with HFNO, because the Florali trial basically said HFNO patients did well with reducing the mortality, but this study did not show that. I think that's what they wanted to look at. And the ICU mortality and length of stay, there was no difference between these 2 groups. So this was the 3rd meta-analysis. And then there was a network analysis that came by the Canadian group in 2020. Even here, they showed HFNC reduced the intubation rate. And as you see, the confidence intervals were significant. And this is the forest plot, which shows the significance. So all in all, so these were 5 studies which I showed you. So one is a randomized control, which paved the pathway to all this meta-analysis. So 4 meta-analysis, and the 3 meta-analysis, 2 from Canada and 1 from China, which clearly showed that in hypoxemic respiratory failure, HFNO does have some merit in reducing the intubation rate and improving the comfort level of the patients as well, and improving the dyspnea. Even the negative study, the US study showed it improved the comfort levels and the dyspnea. So this is the body of evidence we have at this point of time for hypoxemic respiratory failure. So we'll move into the immunocompromised patients, because this is also a very important group of patients who come to ICU with respiratory failure, and we need to understand as to how these patients need to be managed with oxygen delivery devices. So this was a good study which came from the French group. So for all the listeners, I think French have done the maximum, seem to have done a lot of studies in HFNO. So this came from the 9-1 study group by Azoli group from the French. It was a prospective study of 1,611 patients. So HFNC in this particular study reduced the intubation rates. And then there were 2 post-hoc analyses again came from the French group. The REVA network is the one which did the Florali study. And there was another study which came in 2017. Here they did not show any difference with the intubation rates. But there was one randomized controlled trial, which is called the high randomized controlled trial, which predominantly looked at immunocompromised patients. So they took at 778 patients and they compared HFNC and the conventional oxygen. And they found that PaO2 by FiO2 ratio significantly improved with the use of HFNO, and tachypnea also significantly improved with the use of HFNO. But all these other indicators, the endpoint indicators like mortality, intubation rate, length of stay, dyspnea, comfort, there's no difference between the HFNC and conventional oxygen therapy. So immunocompromised, so we have one French study, which is a prospective one, which showed reduction in intubation rates. Others did not show difference with regards to reducing intubation rate. But as you see, the high randomized controlled trial, one of the positive things is it did improve PaO2 and it did reduce the tachypnea as well. So this is the body of evidence we have for immunocompromised patients. Then let's look into post-extubation respiratory failure. So we have two randomized controlled trials. So this was a trial which came from the Spanish group. It came in JAMA 2016, which was a positive study. 527 patients randomized to HFNO and conventional, and they found the intubation rate was significantly less in HFNC as compared to conventional oxygen therapy, in especially post-extubation respiratory failure. And respiratory failure also was less when HFNO was used in comparison with COT. But the limitation of this study was the blinding in this particular study was imperfect. And there was a significant bias because they took predominantly post-surgical cardiothoracic sort of patients in this study, which was possibly a potential bias. Then there was this trial called OPERA trial, which came from the French group in 2016, again to look at post-extubation benefit of using HFNO. So they took mainly post-abdominal surgery in these patients, because abdominal surgery, they would have some splinting of the diaphragm and atelectasis and so on and so forth. 220 patients compared between HFNC and COT. Again, there was no difference with the respiratory failure between these two groups. So these are the important sort of trials that came in post-extubation respiratory failure. So now we look into post-surgical respiratory failure, because there were 9 meta-analyses. There were 9 randomized controlled trials and 2 meta-analyses. So this particular study came from the Chinese group in 2018. It was a meta-analysis of 7 trials, 2,781 patients, where reintubation rates, as you see, was no difference with HFNSO because confidence interval was not significant. But in the patients where reintubation rate they looked at, they took a subgroup of patients who were critically ill. So they took a subgroup analysis and only looked at critically ill patients. There it did show reduction in the intubation rates and it attained statistical significance. And so in post-surgical respiratory failure who became critically ill, possibly the use of HFNO helped in reducing the intubation rate is what they subscribed to in this particular study. Then this was this Canadian study which we spoke in hypoxic respiratory failure. They did the subgroup analysis predominantly in the post-surgical patients, where they showed intubation rate was significantly reduced with the use of HFNO. As you see, confidence interval is significant, and the need for escalation of respiratory support also was significantly reduced in this Canadian study. So it attained statistical significance. So all in all, so I covered the 4 groups of patients in hypoxic respiratory failure. We had 3 meta-analyses and our Floralis trial, which substantiates that it did show reduction in the intubation rate. In immunocompromised patients, we saw one prospective study which showed a good substantiation that it reduced the intubation rate. And post-extubation, we saw one positive and one negative. And then in post-surgical, we have these 2 sort of a meta-analysis which seem to give a signal about its benefit in reducing the intubation rate. So this is the body of evidence, and these are the typical patients we see. So the take-home message that we can draw is there seems to be a good scientific plausibility for HFNO use, even from the technical standpoint and the physiological standpoint. It makes sense. It gives good humidification. It gives a very high flow oxygen, and there is a good comfort level. It does have good mucociliary clearance, and it reduces rebreathing. It improves alveolar ventilation. It reduces the dead space. So all these physiological aspects, it does have a good scientific plausibility that yes, HFNO possibly has a place in our ICU and is a very good adjunct. And I use the word, it is a very useful adjunct as a high flow oxygen delivery device in ICU. It is an adjunct, which means I wouldn't say you use this, patients will all survive and they will get better. So it is an adjunct like any other respiratory device. If patient needs it, we use it, and it helps him to tide over the crisis, well and good. So that is where its role is. And there seems to be a good body of evidence, as we discussed, in hypoxemic respiratory failure, immunocompromised post-extubation, and post-surgical respiratory failure. But an important message to all the listeners is it is not a substitute. So don't look at it as a substitute for NIV. Don't tell that this will replace NIV. So this has its own space, this has its own role, and we saw that in COVID, we saw that in interstitial lung disease, we see it in many groups of, we see it in palliative group of patients. And it is not a substitute for intubation thresholds. So your intubation thresholds are determined by the clinical context and the patient's response to the oxygen delivery devices, and the patient's trends in the improvement is what should determine. So that is a very important statement I wish to make. So it is a good adjunct, good place in ICU, reasonable body of evidence, but don't look at it as a substitute for not intubating or not putting, not using NIV if they are failing on this for any other reason. And most importantly, look at the patient, look at the clinical trends, and look at the clinical progression, and look at the clinical context to determine its usage. So thank you everyone. So I end with this beautiful quote. So better keep yourself clean and bright. So we are the window through which you must see the world. So thank you.
Thank you, sir, for the excellent presentation. As you rightly said, there are these evidences, especially there have been many evidences in favor of its use, but still these devices are being underused. I hope the awareness will become more, and everybody starts using these kind of machines at the right setup. And as you said, it's not the replacement for an NIV or intubation. And we'll move on to the next topic. We'll take the questions at the end.
Yeah, Himol, I have a privilege of introducing one of our very good friends of Sunil and myself, Dr. Sumesh Arora, a very senior consultant specialist from Australia. He works at Canberra. That's right, Sumesh. So he's a very good friend, and so we have him as a panelist along with us. So welcome aboard, Sumesh.
Pradeep, thank you very much for having me. And Sunil, so many years ago, you know, I'm seeing you after such a long time. It's very nice. Good to see you.
Yeah, thank you so much, Sumesh, for joining us. Yeah.
Thanks for joining, Sumesh.
Thanks, Dr. Sumesh. So the next talk will be by Dr. Sunil Karanth. It's on the topic of airway humidification. Dr. Sunil Karanth is the chairman and consultant intensive care, Manipal Hospital, Bangalore. He holds FNB degree and EDIC degree, and he has completed his FCICM from Australia. He is an expert in neurocritical care and point of care ultrasonography. He is registered under APRA and is a fellow of ANZIC and FCICM Australia. He is a senior teacher and examiner for National Board and ISCCM. He has authored a lot of chapters in national and international textbooks, numerous research publications in his name, both in national and international journals. He is also a senior national faculty in various regional, national, and international conferences, and he's also been the joint organizing secretary for National Conference Criticare 2015. So I request Dr. Sunil to start with the topic. Thank you.
Thank you, Dr. Himal. It's a pleasure to meet Dr. Sumesh, and thanks, Pradeep, for that wonderful lecture. So I'll be talking on respiratory humidification or airway humidification, which is an important adjunct to any form of respiratory support. Now, this is something we tend to kind of, can you hear me? I'm audible, right?
Yeah, Sunil, you're audible, please.
Okay, thanks. Sorry for that. Yeah. So this is an important, I would say, even often neglected kind of a adjunct when we put anybody on respiratory support. Now, this could be oxygen mask, it could be NIV, it could be ventilation. Now, what is the importance of humidification? As we all know, normal airway physiology, humidification is a very important part of a normal negative pressure breathing, or as normal humans when we breathe. By the time the air passes through the upper airway, about 75% of the humidification is complete. And by actually placing an artificial airway, we are largely bypassing this important mechanism of humidifying the air. So this is something that we need to understand, that anybody who goes on to respiratory support is likely to actually have an alteration or a disruption of this important defensive protective mechanism, which can you mute? Can I ask the host to mute the others, please? Yeah. So it's a very important sort of adjunct or an important protective mechanism for the airway to maintain what we call as the mucociliary transport system, which is a very highly balanced system needed to keep the airway clean. Often we say, I say optimal humidity is what we say is about 37 degrees, which is the normal body temperature, absolute humidity of about 44 milligram per liter, or a relative humidity of 100%. So as you can see here, by the time we have the air crosses the upper airways and reaches almost the carina, you find that the 75% of the humidification is complete. So if you bypass this mechanism, there needs to be something that has to be put into place to ensure that there is optimal humidification of the air that enters the lower airway and beyond that into the lungs, because this temperature and humidification is an absolute necessity to ensure that there is good mucociliary clearance. And as it is, placing an artificial airway is associated with different mechanisms by which we are likely to actually cause alteration of the airway defense mechanisms. Of course, one is the damage to the mucociliary transport system. You have already bypassed the upper airway filtration mechanism, and in suboptimal humidification, you're likely to further damage the respiratory mucosa. So this is something that we need to understand. Now, if you see this electron microscopy photograph, you find that with 100% humidification, this is how the respiratory mucosal lining looks. But if there is a little bit short, 90%, even 10% drop in the relative humidity, or if there is a prolonged dryness or dry air that enters, sometimes they say even up to an hour is enough to cause subsequent denudation of the respiratory mucosal lining that actually causes substantial damage to the airway mucosal clearance mechanism. Two factors which determine: one is the temperature, one is the duration, and of course the extent to which the humidity drops. So in varying combinations, as you can see in this graph, lesser humidity, greater damage; longer decrease in humidity for a prolonged period of time causes damage. So essentially, the factors of decreased humidity, the extent of it, the duration to which the humidity drops causes damage to this important protective mechanism. Now, there are a number of clinical outcomes which happen because of this impaired secretory, because of this impaired mechanism. One is, of course, it predisposes to various pulmonary complications, including increased risk of secondary pneumonia or hospital-acquired or VAP or any other form of secondary pneumonia. Now, if you remember, in the good old days, literature used to describe these kinds of pneumonia as hypostatic pneumonias, which is probably, I believe, a very apt thing, because this is more often because of stasis, damage to mucociliary secretion, and of course, other mechanisms which promote stasis that causes these kind of secondary pneumonias, be it in ventilated patients, be it in post-operative patients, etc. So this is a very important reason for why secondary pneumonias often happen. So if you see in this slide, you find that longer the duration of decrease in ciliary clearance, you find that there is risk of complications. Atelectasis increases with the decrease in humidity, so also it predisposes to increased length of stay. Now, there are multiple factors which actually cause impaired secretion or impaired excretion from the lower airways. Physiological mechanisms such as age and sleep, and we do need to understand that induced sleep that often happens in many of our patients, either during surgery, during anesthesia, or during various forms of pharmacological therapies that we do, can predispose or worsen this risk. Environmental factors such as smoking, dry air, the air conditioning, if not optimally managed, or the AHU, if not optimally managed in the ICU or hospital setting, can predispose to what we call as impaired ciliary clearance. There are different diseases, some of them acute, some of them chronic, which is listed here, which can result or predispose to these kind of mechanisms. And of course, the clinical interventions such as anesthetic drugs, intubation, anesthesia, particularly not only by putting them to sleep, but also directly impinging on the ciliary mechanisms. Then, of course, various other airway procedures such as tracheostomy, intubation, and a whole lot of other things, including simple therapies like even merely administering dry oxygen, can actually result in in impaired ciliary clearance. Now, in short, it is to summarize these, as I said, there are multiple reasons for why a patient in the intensive care unit can have reasons for why the ciliary mechanisms and clearance of secretions from the lower airway get hampered, and it is further exacerbated by various interventions. So an optimal humidity, what is described as a normal temperature of about 37 degrees with 100% relative humidity, is what is aimed for, which preserves the mucociliary function and therefore predisposes or helps in various other clinical mechanisms by which the airway can remain clean. These are a number of humidification devices which can be as simple as saline instillation, nebulization, the bubble humidifier, which is not very effective, I should admit, the HME, and the heated humidifier. The current scientific literature supports the use of HME and the heated humidifier. Now, there's been a lot of debate, and the pendulum has swung for and against the heat and moisture, or HME, or the heat and moisture exchanger. Now, this is, in short, a portable device, a disposable device, which is put into the ventilator circuit. Now, what it has is a hygroscopic or a hydrophobic membrane, which actually facilitates the expiratory moisture to be trapped. And as the inspiratory gases go back, you find that there is humidification that happens. Now, if for any reason there is blockage, obstruction, then you find that this may not function effectively. Now, when these HME filters, or in most of the recent devices or recent manufacturers, combine a bacterial filter as well. So most of the present generation HME filters are heat and moisture exchanger devices, which have a mix of hygroscopic and hydrophobic membrane. So it has both mechanisms. Plus, of course, they have an encompassed bacterial filter. Now, these are good devices, well-tested, time-tested, which have found a significant role in practice of intensive care. Of course, the manufacturer's recommendation of changing it needs to be followed. Between 3 to 5 days, most often it is what is recommended. But we need to understand that even a slight change in the minute ventilation, a change in the quality of the product, can result in marked changes in the humidification ability. So therefore, and in addition to all of that, there are other problems such as increase in the dead space, resistance to flow if the quality of the product is not good, or for some reason you find that there is blockage or obstruction of the membrane because of secretions or excessive water, excessive fluid, can all result in obstruction and increase in the work of breathing. So it's very important to understand that HME is a good device when used optimally, knowing fully what is its side effects and disadvantages as well. So it needs to be changed from time to time, and there are other disadvantages such as a break-in circuit that is often needed when we actually use these HME devices. So for short-term ventilation, HME is probably a good device to use when we do not have problems with excessive secretions, blood, or such other problems emanating from the patient's airways. These are some of the risks that we talk about when we have breaking of ventilator circuit, including derecruitment, which is often a problem in patients with ARDS. So to circumvent this problem, heated humidification systems are present. Now, these are also devices which have been there for over 2 decades. Initially, when these devices were used, there was evidence to say that there was increased risk of ventilator-associated pneumonias. But with more recent technological expertise and technological improvements, this has substantially dropped. I'll show you some evidence to show that there is no benefit of using one over the other. But there are certain distinct advantages of using the heated humidification system. And most importantly, in patients who need long-term ventilation, particularly when the ventilation goes beyond 48 hours, or some authors say beyond 5 days, when there is excessive secretions, when there is a lot of blood or such other excessive secretions coming out of the endotracheal tube, it is probably more advisable to use a heated humidification system. And most importantly, with the newer generation humidification systems, we do see that there is good servo-controlled feedback systems which actually result in appropriate maintenance of the optimal temperature and the humidification, which is the gist of what we want to actually do when we talk about appropriate humidification. Now, with optimal humidification, some of the problems which we face with the ventilation or placement of an artificial airway is often circumvented, and therefore it is often advisable to ensure that there is optimal humidification that does takes place. As this is a small study which did show that patients who did have use of heated humidification system had lesser work of breathing and probably a little improved gas exchange, and most importantly, lesser dead space. There are other risks which do happen with HME or improper humidification, I may say, which includes increased risk of endotracheal obstruction, and many times this can actually go undetected. In our own clinical practices, we have noted that often the bedside nurse or a junior doctor often comes back to us saying that no, the tube is not blocked because the suction catheter is going in freely. Now, one thing that we need to understand very characteristically is that just because the suction catheter goes in, it doesn't necessarily mean there is no obstruction in the distal tip of the endotracheal tube. It is many a time is what we have seen, that the work of breathing is high, the patient's airway pressures are high, but the suction catheter does go in. But when you actually change the tube, you do notice that there is a significant clot or a thickened mucosal mucus plug which is sitting at the distal part, causing all this problem. And all you need to do is change the tube, and you find that the patient starts weaning. Now, these are all problems of inadequate humidification, and it is important to identify that with appropriate understanding of the drawbacks of both types of humidification, the HME or the heated humidifier, it is you have to use the optimal device based on the patient's individual needs. One study did show that there was better tube patency. In fact, this is not the only study. There are a couple of other studies, and I'll show you a meta-analysis, which was a recent meta-analysis, which has shown that airway obstruction, tube blockages are definitely much lower when we actually use the heated humidification systems. The other problems with HME are the increase in dead space. And sometimes if you have not noted properly, there could be a blockage at the membrane level, and therefore it can result in artificial increase in the airway resistance, which often goes away when we actually change the HME or we change it to a heated humidification system. So the work of breathing can technically increase because there is increase in the dead space, and sometimes there could be obstruction or occlusion at the level of the HME. So in summary, the heated humidification systems has its pros and cons. It is probably optimal when we have long duration of ventilation. Now we could say 12 hours, some people say 48 hours, but if the ventilation is prolonged, it is probably better to change over to a heated humidification system. And also depending on the type of pulmonary pathology, those pathologies wherein you have increased secretions, excessive need for humidification, and most importantly, need to have controlled humidification, it's probably better to use the heated humidification system as compared to the HME. Now, non-invasive ventilation for a long time, we believed that didn't need humidification because we all assumed, or the assumption was that it actually is going through the upper airways, and therefore you have optimal humidification happening. But it is very important to understand that NIV results in excessive dryness of the upper airway mucosa. There is excessive mouth breathing, the excessive airflow, or the initial minute ventilation of the airflow actually can itself cause a lot of drying of the mucosal of the upper airway mucosa, which in turn causes inappropriate or inadequate humidification of the air, and therefore causes drying of secretions and damage to the mucociliary mechanism. So it's very important to ensure that people who are on NIV for very long hours or for prolonged period of more than 24 to 48 hours, it may be appropriate to add a heated humidification system. Now, this is one place where HME may not be very useful, particularly when we are talking about a single limb circuit, where the HME gets bypassed completely and the optimal humidification does not happen. So when you are using humidification for NIV patients, it is probably optimal to use humidification systems or the heated humidification systems. One of the reasons for failure of NIV is, of course, patient intolerance and crystal or dryness of the secretions and inappropriate clearance of secretions. In fact, we all do know that excessive secretions is probably a relative contraindication for NIV. But to ensure that you are having appropriate humidification, it is important to have proper humidification systems in patients who are on NIV for beyond 12 to 24 hours. Right. So the practice guidelines from the American Respiratory Council did mention the use of humidification with NIV as early as 2012, and from then on there has been a lot of emphasis for the use of appropriate humidification systems with the use of NIV. Now, this is not a problem that we face with high flow nasal cannula, because the HFNC does come with an inbuilt humidification device, and this could be one of the reasons for why there is, in addition to, of course, the interface, this could be one of the reasons why HFNC is probably better tolerated than NIV. And as Dr. Pradeep has mentioned, from that time we know about use of or the benefit of HFNC with the Florali trial, the indications for use of HFNC have actually broadened, and people have started using it for much larger indications as well. Now, this is one trial in the early 2000s which showed lesser incidence of VAP. Of course, just prior to this, there were multiple other studies which did show that HME did have lower incidence of VAP, but following this trial, there are a couple of other studies which showed that with the use of appropriate humidification systems, heated humidification systems, there seem to be a lesser incidence of VAP. Now, the reason the ventilator-associated pneumonia is higher probably in patients with heated humidification systems in the earlier studies was perhaps more related to the inadequate design and inadequate technology which was existing at that point of time, because most of the early heated humidification systems came with a lot of accumulation of water and moisture in the circuit, which probably predisposed to these infections. Now, this is a recent meta-analysis which has combined over 15 studies and found that there was no major difference in terms of secondary pneumonia with the use of HME or humidification systems, but definitely the heated humidifier system was associated with lesser mechanical problems such as tube block, and better patient tolerance was seen in patients who had prolonged ventilation with the heated humidification systems. So in summary, humidification is an important adjunct for patients with respiratory supports. Now, when I say respiratory support, it is not only mechanical ventilation or airway devices, but even non-airway devices such as oxygen and NIV is associated with significant humidification issues. So it's very important to ensure that we have optimal humidification, which happens in patients who have prolonged need for respiratory support. And I'm putting a very broad term for respiratory support, which could mean anything varying from simple nasal prong oxygen to mechanical ventilation. It is also important to ensure that the choice of the humidification system is appropriate, and we know the pros and cons of be it HME or the heated humidification system. And probably if the need for respiratory support is prolonged, it is more likely beneficial to use heated humidification system, especially with the newer technologies which do come with the servo feedback loop system, which optimizes the temperature as well as the humidification at the level of the endotracheal tube tip. Thank you.
Himaldev, you're still mute. Can you please unmute yourself?
Thank you, Dr. Sunil sir, for an excellent talk and an elaborative talk. You have clearly explained which all scenarios the HMEs and the heated humidifiers can be used, and not only in the intubated patients, it is necessary in NIV scenarios as well. So there are a lot of questions. We'll start. I'll request Dr. Pradeep Rangappa to answer some of the queries. So one of the question is, does high flow cause nasal mucosal trauma? And can we use the high flow nasal cannula post skull-based surgeries?
Yeah, thanks, Himal. So nasal mucosal trauma, I have not seen too much of excoriation or ulceration, but albeit prolonged usage with inadequate humidification possibly can lead to issues, crusting of nasal mucosa and dryness. But since the humidification is the key thing, that is an advantage which we spoke about, which possibly prevents this. Honestly, I have not seen this as a problem, but I would request Dr. Sumesh also to pitch in because they use a lot of HFNO in Australia. I think many people may already know Sumesh. So he works at Sydney. Isn't it, Sumesh? You work at Sydney.
Yeah. Yes.
Pradeep, if I may
Please
pitch in,
Sumesh.
I had the honor of being with Sumesh when we were in Westmead. He was my colleague at that stage. Sorry for intervening.
Sunil always gave me inferiority complex, always.
Yeah, and many trainees would know Sumesh is popular for his go the extra mile. I think a lot of people take good ranks reading his go the extra mile stuff. Many of the trainees here who may be listening to this would know about Sumesh. Over to you, Sumesh, on your comments on this nasal mucosa conservation.
Well, I suppose look, we've used a lot of high flow nasal prongs in patients who get neurosurgery, particularly for skull base. I suppose patients who come back after transnasal transsphenoidal resection of the pituitary, in those patients, the risk of CSF leak is high, and we avoid high flow nasal prongs as much as possible. If at all high flow nasal prong is contemplated in these patients, it should always be a shared decision along with the neurosurgeons, not only to get their opinion, because they know they have been through the nose, they know what is the status of the cribriform plate, they know whether they have put in a pad of fat over there to seal any potential leak. And if you do not tell them and it leaks later on, you get the blame, and not a pleasant thing actually to be in the end. So I think among the surgeries for which we do not use high flow nasal prongs, among the neurosurgeries, I think transnasal transsphenoidal resection of the pituitary is the most important that come to mind. Surgeries in which patient's nose has been operated on would be obvious contraindications. Another group of patients for whom the similar question comes up is patients who have had esophagectomy. So ours is a center which does a fair few Ivor-Lewis esophagectomies, and often the anastomosis is quite high in the chest. And the question always comes, is high flow nasal prong okay in these patients? My understanding is that for somebody on high flow nasal prong, it is really difficult to know whether there is indeed any PEEP generated from high flow nasal prongs. The current evidence I understand points towards maybe around a centimeter of PEEP with every 10 liter per minute increase in flow with high flow nasal prongs. And once again, if we are to give high flow nasal prongs in post Ivor-Lewis, we try and make it a shared decision alongside the surgeons. So in short, the transnasal transsphenoidal pituitary resection and Ivor-Lewis and nasal surgeries are the ones in which you may want to steer clear of high flow.
Thank you, Dr.
Just to extend to what Dr. Sumesh said, I think very rightly, as Dr. Sumesh pointed out, the route of neurosurgical intervention determines whether nasal cannula, high flow nasal cannula can be used at all or not. But I'd also take the argument one step further to say that we need to understand that HFNC, in terms of evidence, has been most importantly seen in surgical or surgeries which have involved upper abdomen, thoracic, where the splinting is the main issue. So the reason HFNC is often used to ensure a certain amount of recruitment, ensure a certain amount of upper airway to remain open. So if you feel that a patient with any neurosurgical intervention often needs HFNC, most often it is because of the fact that there could be, because of the fluctuating GCS or something of that sort, where the patient would be probably better off going on to a ventilator or something of that sort. So I think the choice where we use it, it needs to be extremely careful. Now, there are certain instances where we have used HFNC post-extubation after neurosurgery in people who have had pre-existing problems, like, say, for example, obstructive sleep apnea or such other things, where the route of entry is not transnasal. It could be some form of craniotomy or craniectomy. But rightly, as Dr. Sumesh said, it has to be a shared decision. For esophageal surgeries, if many of the current surgeons do allow us to use HFNC more than NIV, especially when it is a robotic esophageal surgery where the anastomosis is much lower. If the anastomosis is much higher up, like the typical 2-stage or 3-stage Iver-Lewis, where the upper cervical anastomosis is very close to the HFNC, they may be a little reluctant. But if it is robotic surgeries, they are quite okay to use because it is quite far away. But they would prefer HFNC over NIV. So I think it's very important to discuss with the surgical team before we decide on placing these patients on HFNC.
Thank you, sir. It was very clear. The other question is for Dr. Sunil Karanth. There is a perception that heated humidifiers promotes the growth of infections like Klebsiella and Acinetobacter. So what is your take on that?
Yeah, there is no clinical evidence to back it, at least in the more recent data that we have. And as I told you, even if you look at the most recent meta-analysis, patients with the pneumonia, they looked like there was a probable trend towards better trend towards use of HME, but it was still not crossing the unity. If you look at the meta-analysis graph, but there is nothing to suggest that. And most importantly, the new generation humidification systems are closed circuit devices. Even the water that gets distilled water that gets filled into the chamber is actually continuously connected to a closed loop system. So all you need to do is to ensure that the valve is opened whenever you need water to be filled into the system. So there are certain precautions that we definitely need to take. Make sure that there is no stasis of water that happens in the circuit. Make sure that the circuit remains empty. And the current generation ventilator circuits don't even have a water trap, because if you're using the humidification systems which have the servo loop, ideally you should not be having water collecting or trapping in the humidification system. If you start having water trapping, then there is something wrong with the servo loop system. So there is no recent data to support it. And I think if humidification is a necessity, then you have to go ahead with using the heated humidification system.
Agreed, sir. I think that clears out and people can negate that. Another question is for Dr. Prangappa. It's a common perception that HFNC consumes, it's not a perception, it's the fact, it consumes more oxygen as compared to other conventional therapy. What's your suggestion? And
I think that's a very good practical question, Himal. We had this problem in the second wave COVID. I think Sunil would recall. I think all the people present here, we were doing the tele-ICU rounds for district hospitals in Karnataka. So we had this huge problem with oxygen issue, oxygen demand supply. There was a huge sort of a problem in second wave. Towards the later part of the second wave, there was a dearth of oxygen, and there was some of the hospitals, I distinctly remember in Hubli. So we used to have problem where more HFNOs were being used, because Hubli hospital had around 75 ICU beds, and the amount of oxygen that they were needing at this point of time was enormous, and the supply was dwindling at that point of time. And HFNOs, we did have issues with overt oxygen consumption, and there were these lines. We had issues where oxygen pressures used to suddenly drop, because when the when the oxygen piping length increases, because there were two buildings and apparently the tubings to one building was a bit long. And whenever HFNOs were being used, the pressures used to drop and there was a problem with oxygen delivery. So all this led to us revisiting our protocols. Here, that initially when the COVID came, there was a huge emphasis on the use of HFNO as opposed to NIV. But later on, we realized the science of oxygen delivery and the science of taking care of critical and well patients pretty much remained the same as in any other case. And there was no very uniquely distinctive features which would change our basics of intensive care practice. So that is where we were at that point. So, and Sunil, you would recall that we revised the protocol and we put an emphasis that HFNOs were sort of de-emphasized at that point of time, and we were sort of moving to using more NIVs at that point of time, where oxygen supply was a huge issue. So I agree, it was an issue, and we did do an oxygen stewardship program recently also to all the district hospitals, de-emphasizing on hyperoxia, because people were using oxygen indiscriminately, aiming 100% saturation. And we know for sure now there are multiple trials which have shown the harmful effects of superoxygenating or maintaining hyperoxia. So that's why we embarked on our protocol trying to target our oxygen saturation about less than 96% and not to aim at 100%. And even we put up a weaning protocol for all the government district hospitals to conserve the oxygen. And recently, just 2 weeks back, me and Sunil were part of this oxygen stewardship program, which we did for around 350 government doctors across our state, Himal. So the simple answer is yes, we should be cautious about the oxygen usage, especially when we're using HFNO, and always titrate it to the optimal need for oxygen and don't super oxygenate people. I think that would be the message. So appreciate comments from Sumesh on this and Sunil as well. And Himal also, comments would be relevant.
So I think that holds good not only for HFNC, but also indiscriminate oxygenation for, with the other devices also. Because you see, it's very common to see 99% saturation patients. They are just, somebody walks into the ICU, they get slapped with the oxygen mask. So I think after the second wave, I think people have realized the importance of oxygen. And as you know, the government has come out with the guideline that any more than 100-bedded hospital needs to have their own oxygen generating unit, and such other guidelines have come out. But I think it's important to ensure that or treat oxygen as a drug, and there are it's not as safe as we thought, or it is believed to be. Just like people put everybody on IV fluid when you walk into the hospital, everybody gets started with oxygen. So I think it's very important to be very judicious with the use of oxygen, irrespective of using HFNC or not. Dr. Sumesh, your valuable thoughts.
No, I agree. There have been a multitude of trials in the last 3 or 4 years which have suggested that supplemental oxygen in patients who are not otherwise hypoxic may worsen their mortality. And I suppose the economic aspect cannot be overlooked either. Following the publication of one of those trials, we were doing a back of the paper calculation on, like in our hospital, it is a policy that every patient who is on PCA with fentanyl or morphine or any opioid must get 2 liters of oxygen per minute. That is the minimum, and a fair number of these patients are not hypoxic. And if we make a calculation, 2 liters per minute, 120 liters per hour, times it, 24 times. And then we have, 2,800 liters of oxygen per day per patient. You put 50 patients on PCA in a day at any hospital. And that's like 50 cylinders of oxygen, which we might as well preserve otherwise. So I think the economic aspect of anything which doesn't come with a definitive price tag gets overused, abused, and I agree we should absolutely treat oxygen as a drug and use it miserly, only just as much as we really need. And I could not help but think, I mean, we weren't affected with COVID as much in Australia as, as India was, particularly around April 2020, April 2021. And I could not help but feel that high flow nasal prongs was somehow partly responsible for the oxygen crisis which many cities faced. But then this is an outsider's view.
Well, your viewpoint, Simon, because you also must have been using.
So we also had the same kind of the queries and questions. And I also agree that it has to be judiciously used. And as Dr. Sunil has said, not everybody who comes into the ICU should be slapped with oxygen. And it has to be judiciously used. So I think we are running out of time. If you are okay, then we'll conclude the session, sir.
Yeah, thank you very much. I think, yes, I think we could possibly conclude. So any final thoughts from Sumesh, Sunil, and Himal also?
We will start with Dr. Sumesh.
Look, I had a few thoughts on, I was involved in a guideline for ventilated patients a few years ago, and the issue of heated humidifier versus HME came up. And I had to dig a bit deeper because it appeared on paper that the two therapies, the two modalities of humidification were equivalent. And one of the things I realized, and as Sunil touched on it in his talk as well, was that majority of the trials which compared HME with heated humidifiers were done in the 80s or 90s. And in those days, heated humidifiers were a relatively new therapy. And inline heating of the inspiratory limb of the ventilator circuit was not a common thing, which now is a standard of care. And Fisher and Paykel, indeed, they have integrated heating wire in the inspiratory limb, and the expiratory limb does contain a heated wire as well to minimize the raining of the circuit. And secondly, at least some of those studies excluded patients with high secretion load, with the assumption that the HME would get blocked in those patients and therefore may prove to be inferior. So the very group of patients who may have benefited more from heated humidifier were excluded from the studies. And as a result, what we got was equivalence of the two groups. But I think patients who require mechanical ventilation for a long period of time, my opinion is that that heated humidifier is the way to go with the advances that we have in the last 20 years, and minimize the number of circuit disconnections, because HME needs to be changed every few hours. There was something else in my mind about that. Yeah, I think heating wire and removal of patients actually with high secretion load. And I suppose once the patients are on spontaneously breathing in tracheostomy, we use what is colloquially known as a Swedish nose in here, which is like a tiny HME which connects just to the tracheostomy, and nowadays have a capability of connecting some supplemental oxygen onto it as well.
Thanks, Sumesh. I think we call it as thermovent here. We used to call Swedish nose in the thermovent is the name which we commonly use here. I think one additional advantage of humidification with heated humidification, which I often cite, but Sumesh can correct me here, is the temperature regulation we have with the heated humidifiers, which possibly we may not be having that effectively with HME filters. So do you think that also is a distinct advantage, Sumesh? I always say that's an advantage.
Look, I suppose HME is meant to control, I mean, it is heat and moisture exchanger. So it should have an element of warming the inspired gases as well, and humidifying also. But really there is no number that we can bank on. That we do not know what is the temperature of inspired gas, which may drop down if the minute ventilation is high, and we do not know the relative humidity of the inspired gas either, which again may drop down if the minute ventilation is high. And also, I suppose, like like Sunil said that, the quality assurance of these products is really important. So let us say that we have a HME which has a internal leak somewhere, that there's a low resistance bypass pathway. So if there is a low resistance bypass pathway, almost all the inspired and expired gas may go through that bypass pathway and none through the filter itself. But we won't know about it. So I think quality control of the HME is paramount. They must pass through the most stringent tests.
I think Dr. Sumesh brought out a very important point about the minute ventilation, because that is something which you really need to be aware. As Dr. Sumesh pointed out, when the minute ventilation goes beyond a certain level, I think the effectiveness of HME definitely comes down.
I think one other important aspect which possibly I didn't cover, maybe a few audience are left already, about the distinctive advantage of HFNO, Sumesh, which you would agree, which I found very much used in Australia, was all this interstitial lung disease where you predominantly have a diffusion impairment, where you need high oxygen and where they are palliated to not to get intubated. This was very useful in ensuring reasonably good quality of life for these patients towards the end. Where NIV possibly would be looked at as more intrusive and more painful sort of an intervention to maintain. And NIV wouldn't help in these certain lung conditions where diffusion impairment. So, and even palliative is underemphasized, where I have used it. Even now, I tend to use this in some of the palliative patients, where HFNO scores better than NIV in these patients as well.
Yeah, I totally agree. I think the palliative patients, they almost universally absolutely hate non-invasive and find high flow pretty easy to use.
Have you used it in the wards or in the tracheostomy patients? I'm sure you would have used it in tracheostomy patients.
High flow nasal prongs?
Yes.
I have never connected high flow nasal prong to a tracheostomy, no. I don't have any experience of doing that.
Sunil, sir?
No, I have unfortunately. I think the having connectors and having a conduits to use this has been an issue. I think we tried once, but we failed. I think it was not that easy. No, the answer is I haven't used, but we attempted once and we failed. Maybe we should work on this, Himal.
Actually, the problem is not available or unavailability of the right kind of connectors to connect it to the tracheostomy. There is a lot of leak which starts generating, and the whole advantage of the high flow goes away.
Right.
What we often do, however, as part of tracheostomy weaning is when you really want the patient to be having speech and you want them to have the tracheostomy cuff down, or sometimes you downsize the tracheostomy and use it just as a conduit for suction, but not use it otherwise. In those cases, we have used either tracheostomy is downsized and capped, or downsized and is, Passimure valve is connected, and we use high flow nasal prongs or CPAP or BiPAP using a oronasal mask, but never connected high flow nasal prongs to the tracheostomy itself. And indeed, if it is connected to tracheostomy, I imagine that a protocol will have to be in place to ensure that the cuff is always down, because we connect high flow nasal prongs to somebody with a inflated cuff, and next thing you know is a pneumothorax or tension pneumothorax in no time. And I think something to be approached with extreme caution.
Thank you, Dr. Sumesh. So any further thoughts?
Look, if I may ask a question, actually, just to raise a discussion, if we have maybe a couple of minutes.
Please, sir.
Yeah. This question has bothered me a lot, and I don't claim to know the right answer. So I'm going to put Pradeep on the spot here. So look, let us say that, so we don't really have a, we do not really know if for hypoxemic respiratory failure, conventional oxygen therapy versus high flow nasal prong versus non-invasive, if one or the other is better, right? So let us say that we go to the ward in the morning for the round, and there is a patient who has had a partial gastrectomy, let us say, 1 day ago, and is now hypoxic. This patient may have had, let us say, aspiration versus collapse, or maybe a collection after esophagectomy, a collection of fluid in the chest or such things. The pathology could be quite variable. And then you think that conventional oxygen therapy is not working. I have to use either high flow nasal prongs or CPAP or BiPAP, right? And on paper, high flow nasal prong is not inferior to non-invasive ventilation. But in your head, when you make decision, you will say, oh, no, not high flow nasal prongs. I want to give CPAP or BiPAP to this patient. I actually want to ask the question, when would you use CPAP or BiPAP straight away without giving any time on high flow nasal prongs? You must have some subconscious way of deciding.
Yeah. So I think the way possibly I would look at it, Sumesh, is if the patient is very delirious, non-cooperative with a lot of cardiac problems, and one additional problem that possibly I would add to the list of problems you said is any acute deterioration with all these elderly patients with a lot of comorbidity who become crumbly, they do have cardiac component to some extent. So if I'm looking at having that component who is delirious, who is non-cooperative, who is elderly, possibly NIV at that point of time may be a little difficult, but if it is a cardiac component, I would straight away jump to CPAP, because there is no doubt at that point of time. But if you are thinking of purely, sort of a worsening lung injury or due to SIRS response, sepsis, delirium, where I just he just needs a little bit of oxygen, then I may use HFNO because compliance and comfort and his ability to comply with it may be much better off than sticking him on a NIV, because NIV is a lot more labor intensive, Sumesh. And in India, I don't know if I could say this, we have huge issues with the nursing ratio, and in NIV, you know how important is a nursing role in making them adapt and comply to NIV. So that is a problem, is something which I would see. Then obviously HFNO would be my first choice in my country, in India. But if nursing ratio is very good, if patient is cooperative, he has cardiac component to it, definitely CPAP. Or as you already said, if they have COPD or other issues, then BiPAP. So somewhere this thought process should run in the mind. And even if you look at the literature in all HFNO, it is always the availability of the equipment and the flow meters and all those ancillary tools that may be needed. So if it is easily available, yes, I would prefer HFNO as an intermediary and then move on to other invasive. Just the comfort factor and the ease of communicating with the families, that also becomes terribly important in these patients. So if those are the choices that I have to make, those are the boxes I need to put, HFNO would be the way. But if I'm looking at cardiac component, other pre-existing lung problem, then NIV is something. And you rightly said that gastrectomy and all this anastomosis, surgeons' shared decision is something that we need to make. So if I'm not having a consensus from other teams, or it's the middle of the night, then I prefer possibly using HFNO to tide over the crisis and then talk to the surgeons rather than waking him up at 3 a.m. and asking him, is it okay, I can put him on NIV, because I may piss him off use time. so that's
so easy to do that.
Yeah. So I would look at it that way. So hope that answers your question.
No, it does.
Yeah. Sumesh, interestingly, I have another good friend from Australia, Vishwanath. He has message saying that he uses trachea high flow to tracheostomy. He's from Adelaide. I think you must be knowing. He has put it on the chat box. Trachea high flow, hello, he has mentioned.
No, I have never used trachea high flow, but I just have never come across it.
I think we should work on this, Himal. I think maybe in one of our things we should talk to Fisher and Pickle and see if we have connectors and wherewithal to put this on to tracheostomy patients.
Right, sir. Right. I think we should conclude the session here.
Oh, Vishwanath is here. Hi, Vishi. Vishi is from Adelaide.
Yeah. Hi everyone. Thank you,
I
Pradeep.
think
It was a
Himal, you must be
wonderful,
knowing Vishy. You are in
Yes,
Adelaide.
sir.
Himal.
Yes.
No, we haven't crossed paths. Vishwanath
I-
Sumesh Arora from Prince of Wales, Sydney. How are you?
Hi. I'm Vishnath. I work in Lyle McEwen Hospital, Adelaide currently. I was in Canberra previously. Yeah.
Right.
Yeah. It was excellent presentations by both. As usual, I have a really privilege. Sometimes I join most of the times these topics from the Bangalore chapter whenever they join. Yeah, this is regarding the trachea high flow. We actually use very often trachea high flow. You have got a small connection which comes as a small mask just over the tracheostomy. And we actually use it as a basically as a humidifier for the weaning for the tracheostomy, and it's very useful. We have noted, and we use it very often. That one, yeah, it can be used. Fisher Paykel actually can provide a little bit of a small trachea high flow, which just sits over as a trachea mask. You can mean, but it just sits over the trachea. Yeah.
Right.
Thanks, Dr. Vishwanath. So do you deflate the cuff at that time, or what flow do you set it at when you use it?
Yes, we can actually deflate the cuff as you normally do when you're weaning the tracheostomy, and we usually keep 30 to 50 liters of flow as what exactly you do as a nasal for the nasal prongs. Okay, it is usually very good, especially if the clearance of the secretions and all that. We also have something other device, some Swedish nose. I think we would have heard that also can be sometimes used, but that is actually we try to avoid, especially if the patient has got a lot of secretions. Then it is not a good one. But trachea high flow we use. You can deflate the cuff, or even if you inflate the cuff, doesn't matter.
Right. Thank you so much, Dr. Vishwanath, for joining us.
Yeah.
Any other thoughts and questions, Dr. Pradeep sir, Sunil sir, Sumesh sir?
No, it's great to have our good Australian friends joining us. So maybe Himal, Bangalore should collaborate and have more of Indo-Australian sessions like these. Because I have another friend, Shankar, who's my trainee, who is joined in from, I don't know which city he's in, Adelaide, I mean in Australia. He's also messaged me. So maybe going forward, Sumesh, we should have more such joint collaborative meets.
Yes, certainly. I would like
I know,
that. You run
I know it's
so
late
well,
night for you.
actually.
It must be 11 or 12 midnight for you guys, but still you have joined. So we really appreciate that, Sumesh, and wish you.
Yeah, it's been many years since I studied anything at this late in the night. I usually just watch movies.
Yeah.
Let me take my privilege. Pradeep was my senior and from the St. John's Hospital. We actually even senior in Queen Elizabeth Hospital in Adelaide here, Royal Adelaide Hospital in Adelaide. And I'm really hats off to you, Pradeep, for your excellent academic the achievements you have achieved in Bangalore and in India. We are really, to be honest with you. This is not, I'm not telling this because we're proud. I don't have to do that at this stage, but I'm really impressed with you. Congratulations. And
humbled.
Karan, Sunil, also I have heard of you, though I have not met you in one or two times. Maybe we would have crossed, but excellent. You people do excellent academic work.
2015 Criticare,
yeah.
We met each other.
Yeah.
Hopefully you guys are coming to Criticare, Sumesh and Rishi. It will be great to catch up with you guys,
Look, not this year, but well, in the same way, and actually, Vishwanath, I should tell that when I was a registrar, I worked with Sunil and Srinivas, who is in Hyderabad, and a guy by the name of Manoj, who is here in Canberra in Sydney, Manoj Singh. And these three, Sunil and Srinivas, I think both of you came from Manipal at that time. I learned a lot from all three of them. Actually, it was the privilege actually of working with you was entirely mine, Sunil. So thank you.
Thank you so much. Thank you.
Great words.
It was a good get together for all of Australian.
I am so pleased to be here. Yes, thank you.
So I thank
Felt like a get together.
I thank Dr. Pradeep Rangappa sir, Dr. Sunil Karan sir, and Dr. Sumesh to joining in this session.
Yeah.
I thank Fisher and Paykel for organizing this session. We'll conclude the session now. Thank you and good night to everybody.
Yeah. Thank you, Sumesh. We'll catch up soon. Thank you, Vishy, for
Take care.
joining us.
Thank you very much.
Thank you, Himal.
Yeah, bye.
Thank you. Thank you, everyone.
Take care.
See you later.
Thanks so much. Bye.